Hey, good morning, everybody. I'm Brad Call, and I'm happy to introduce our speaker today. So this is the Jonathan Jonas Annual Lecture. I want to thank the Jonas family again for the support of this lecture that we do every year. We bring in an internationally known expert in the area of lymphoma to give us a talk, and this year we're very fortunate to have Dr. Steve Ansell from the Mayo Clinic. Steve is the Dorotha W. and Grant L. Sundquist Professor of Medicine in Hematologic Malignancies Research. He's a consultant in the Division of Hematology in the Department of Medicine at the Mayo Clinic in Rochester, Minnesota. He currently serves as the chair of the Division of Hematology, and he's the Enterprise Deputy Director of the Mayo Clinic Cancer Center. He joined the Mayo Clinic in 1999 after having trained in his home country of South Africa. Steve has been a real force in the field of lymphoma in the past 25 years, making really enormous contributions to the field in a variety of areas. His laboratory work focuses on intratumoral T cells in the microenvironment in the different lymphomas. He's been a very productive translational laboratory researcher, and he's really a fabulous clinician. And he's made some very seminal contributions to the area of Hodgkin lymphoma management, and today he's going to talk to us about management of classical Hodgkin lymphoma. Thanks, Steve.
Well, thank you, Brad. Thank you very much for the invitation to be here. I'm really grateful, and goals this morning are to tell you a little bit about the management of Hodgkin lymphoma, why should you care about Hodgkin lymphoma, and share with you about why this is important. I'll just preface it by saying it's really important, particularly if you're in general practice, for two reasons. One, it's a cancer that we routinely can cure. So we want to get it right. We want to give the right therapy at the right time. And number two, it has a bimodal distribution, meaning actually young people get this and then older people, but 2/3 of people that get Hodgkin are young. And so when you cure them, they're around for a long time. And the key question is, can you manage any complications that might have been brought on by the therapy we gave? So whether you're an oncologist, hematologist, whether you're a general practice internal medicine person, whatever your role, if you're pediatrics, this has relevance, I hope, to you. So again, I guess this is just to clarify some of my disclosures. I will disclose that, we do a number of clinical trials. I've been the principal investigator on multiple of them, and they were sponsored by these companies. So although I don't get any money, I need to disclose that that is what is true. So I wanted to tell you make that four things that I think hopefully will be important. Number one, I want to talk a little bit about biology. What exactly is Hodgkin lymphoma? What do we know about the biology of Hodgkin lymphoma? And why does that matter? And the preface to that is, it matters because it's given us new targets, as in how to treat people with Hodgkin lymphoma. And I'll share with you how that came about. Number two is, when you see a patient, what do you need to know about the disease so you can get the treatment right? And so the importance of staging the patient, the importance of understanding prognostic factors, because that determines choice of therapy. And so that's important, and hopefully you'll be able to just share some of the information related to that. The bulk of what I'm going to talk about is managing Hodgkin lymphoma. So as I mentioned earlier, we can cure this a high percentage of time. So we want to get it right. And we also want to get it right with the minimum long-term side effects. So again, I'll share with you some of the trials that have led us to how we manage patients now. And then heaven forbid you're a patient where the cancer did come back despite the best frontline therapy. The good news is that all is not done, because we have multiple salvage therapies which are very effective and can cure another large subset of patients. So again, we want to choose wisely. And so I'll share a little bit about the management of relapsed Hodgkin lymphoma and options for those patients. So what you're seeing on the slide here is really the histology, if you like, of Hodgkin lymphoma. And the reason I'm showing it to you is two things. Number one that's really interesting is, if you can see these little arrows here, you can see the Reed-Sternberg cells, and they are buried in an extensive sea of other cells that are not malignant. So the important thing about Hodgkin lymphoma is that only 3 to 5% of the cells in the tumor are actually cancer. Here you can see the Reed-Sternberg cell highlighted, but all of these cells that you can see around that cell are all normal cells, recruited in by the malignant cell. The reason that, again, is important is if you just simply stick a needle in to get a biopsy, you may miss these cells and suck out normal cells, and the pathologist may be forced to tell you this is an inflammatory reactive lymph node and not this is Hodgkin lymphoma. So an important message always is get an excisional biopsy if you're suspicious about Hodgkin lymphoma. Down here you can see staining for a protein called CD30, and that is on the outside of these cells. CD30 is an activation marker. These cells are crippled, atypical B cells with no B cells markers on them, but they do have CD30. CD30 is important because an antibody drug conjugate called brentuximab vedotin that I will talk about a lot coming up here targets that, binds to CD30, delivers a toxin to those cells. What you see here is FISH analysis looking for copy number gain and amplification of chromosome 9p24.1. That is very typical in Hodgkin lymphoma, and what it does is it is the locus for PDL1 and PDL2. So what's interesting about Hodgkin lymphoma is that Reed-Sternberg cells have very high levels of PDL1 and PDL2 on their surface, and those of you that treat oncology and treat patients with oncological problems will know that PD-1 blocking antibodies are used in a wide variety of places, but in Hodgkin lymphoma that has been a very significant success because targeting the PD-1, PDL1 interaction specifically inhibits Reed-Sternberg cells. So this is just a cartoon that tells you there are multiple interactions going on between the Reed-Sternberg cell that you see in the middle and all of these cells that are in the microenvironment. And typically these can include effector T cells, regulatory T cells, B cells, monocytes and macrophages. They are all talking to each other, and they are actually recruited in by the Reed-Sternberg cell. And so in our therapies, we're targeting the Reed-Sternberg cells, but we're also disrupting much of this discussion that goes on between these cells. Now, recently, they took a look using circulating tumor DNA and looked to see if they could stratify and classify Hodgkin lymphoma based on some of these biological principles. And I really just want to highlight this to you because this does make a difference when it comes to outcome of patients, because the biology being different might require us, as we move into the future, to think about how we would treat patients differently. 3 groups of patients identified. The first are those that have this inflammatory immune escape kind of mechanism. And what that really relies on is overexpression of the chromosome 9p24.1 that I mentioned. This is a group that has lots of cells, but these cells, the effector cells, these immune cells are all exhausted and dysfunctional. You see a second group over here, and these are virally driven because, as you may know, about 1/3 of patients are EBV positive. Some of them are HSV6 positive, and those patients, again, seem to be different to those that have this inflammatory environment. And then there's a final group that really seems to have more oncologically driven processes, more about cell cycle proliferation, more about loss of MHC molecules, which I'll show you more about in just a second. So why should you care? Well, this is outcomes of patients. So 2 things I'd like you to note on this slide. Number 1 is that is a great Kaplan-Meier curve with outcomes where you can see the vast majority of these patients do really well. But again, if you're a patient, you only care about you don't care about groups of people. You want to do as best as possible, and you can see that even within these really favorable groups, there are differences, and this group right at the top are the oncologically driven, the yellow in the middle here are the virally driven, and the inflammatory environment ones are slightly worse. You can see all of them are doing well, but this particular study was based not on people that got chemotherapy, but also on people that got chemotherapy with immunotherapy, so it is really relevant to all of the patients that we treat today. I'm going to take a few minutes just to show you some of the biology that's relevant and that drives some of this classification. So firstly, this is staining for MHC class 1 and class 2 and beta-2 microglobulin. So you might remember that's the complex that needs to be present so that antigens can be presented to the immune system and the immune system can see the cancer. What's unique about Hodgkin lymphoma is that very many of the patients have loss or downregulation of one of those components. So the way in which antigen is being shown by the tumor or by tumor cells to the immune system is significantly compromised and deficient. Now, I'm not sure why that screen went off. So here what you can see is that this matters when you look at patients' outcome. So this is MHC class 2. You can see that specifically if you have expression at normal levels, you get pretty good results when you treat patients with PD-1 blocking antibodies, for example, and much more deficient outcomes when you treat patients that have loss of MH2 molecules. This is the whole discussion around the chromosome 9 p24.1 amplification or copy number gain. And you can see if you have amplification or copy number gain, meaning that you have very high levels of PD-L1 and PD-L2, those patients do even better when treated with PD-1 blocking antibodies than those that have lower levels of expression. Now, I will just tell you, just when you think you've got it all down and you're working this all out, the immune system loves to just throw in a few curveballs. And here's one of the things that I think challenges us as we think about the immune environment and as we think about the immune system in Hodgkin lymphoma. We always think about PD-L1 and PD-L2 expressed on tumor cells. We forget that it is cleaved and shed and actually floats around in the blood. And when it does that, it can still be biologically active. So here's work that came from our group that just showed if you look at Hodgkin sera compared to normal sera, levels of PD-L1 and PD-L2 are far higher in patients. And we showed that you can actually see that T cells can be inhibited at distant sites using the sera that contain high levels of PD-L1 and PD-L2. So what does that mean? Well, it's not just about what's happening in the tumor. In other words, not just in the microenvironment, it's in the whole patient, hence the macro environment. So again, as we're thinking about how we manage patients, important to remember we need to think a little broader than just the tumor. And just when we thought it was all about T cells, just remember the macrophages and other cells that I showed you earlier that are present are also really important. And this is just data that shows you that CXCR5 positive Reed-Sternberg cells are talking to the CXCL13 positive macrophages, and their interaction is actually of prognostic importance, as you can see right below. So that's a little bit about biology. I want you just to remember Reed-Sternberg cells, minority of cells. High expression of CD30, that's one target. High expression of PD-L1, PD-L2, that's another target that may be relevant. And all of this interaction between the cells needs to be disrupted for us really to get the Reed-Sternberg cells to die off. So now changing gears and thinking a little bit, if you're seeing a patient, what is important as you decide around therapy? And the two things that I want you to be aware of is stage matters, limited versus advanced stage, and prognostic factors matter, as I'll share with just in a minute. So here is early stage Hodgkin lymphoma. And what does that mean? It really means the disease is on one side of the diaphragm. What's interesting about Hodgkin lymphoma, it seems to move in a contiguous fashion from one lymph node group to another, different to other lymphomas which really seem to spread out and go everywhere at the same time. So, in a patient with Hodgkin lymphoma, here is somebody with limited stage disease. You can see the disease is predominantly here in the chest, and there are a number of different prognostic factor and risk factor definitions that we use. I think in principle, the things to remember is the bigger the mass, that's not good. Multiple lymph node groups is not good, and anything outside of a lymph node is not good. And the reason that matters is that within limited stage patients, we take a group that we call favorable, and we take a second group that we call unfavorable, and we treat them differently. So when you're actually staging and working up a patient, you need to know which side of the diaphragm, one or both, and secondly, any of these negative prognostic factors. This is a patient with advanced stage disease. You can see disease on both sides of the diaphragm. You can see outside of the lymph node system. And in general, this is an old staging system that is used less now because the thing that is much more important is how well people respond and using PET scans to determine therapy based on response to treatment. This is really based on, are you a man, which you can't really change, and what do your blood results look like? and that's already a predictor of how you're going to do typically to typical chemotherapy. So I'm going to change gears now and use that information, biology, staging, prognostic factors, and now talk about management of patients. And what I'd like to do is just take you through how we manage patients, kind of what we have typically been doing, and how these novel therapies and strategies using PET scans are changing and have changed how we manage patients. So I think in principle, there are already three groups of patients with Hodgkin lymphoma: early stage, favorable characteristics; early stage, unfavorable characteristics; and advanced stage patients. And in principle, giving an early stage patient with favorable characteristics, the treatment would be to give limited chemotherapy and low-dose radiation treatment. I'll show you how radiation is being challenged, but that's been a standard in the past. Some patients don't need radiation therapy, and that's based on PET scan data, and I'll show you that in a minute. Second group of patients, limited stage but unfavorable characteristics, principle being you need more chemotherapy and you need a higher dose of radiation therapy. Again, could that change based on whether or not you've had a good response on PET scan? I'll show you that in a minute. Advanced stage patients, again, looking at those prognostic factors, if you have low risk, typically more of a chemotherapy basis over 6 cycles, higher risk, especially the Europeans escalated the treatment even to a higher level, particularly in the high-risk patients. So just to now go through each of those in a little more detail, early-stage Hodgkin lymphoma patients. So really, I think, as we've tried to move this field forward, the first key question that's been addressed is, do you really need radiation therapy? The main reason is, as I said right in the very beginning, we're trying to avoid long-term toxicity, and particularly standard old-school radiation, which may have changed now more with proton beam and others, but maybe that was not so great in the long term: cardiovascular disease, second malignancies, other kinds of challenges. So 3 trials, and again with all of this early stage and late stage and advanced stage, I will show you 3 clinical trials that were the basis, and then kind of what has happened since then. So 3 clinical trials, all of them from Europe, tried to test this whole question about, do you need radiation therapy, yes or no? So the RAPID trial was from the UK, and in essence, 3 cycles of chemotherapy, and compared that, and then doing a PET scan. If the PET scan was negative, you could either give radiation therapy, which would be the standard, or stop. For patients that were positive, you gave another round of chemotherapy and you gave radiation. From the French study, pretty much the similar sort of thing. Standard arm was to give chemotherapy plus radiation. Experimental arm was to see whether you could leave out the radiation if the PET scan was negative. German Hodgkin lymphoma study group went a little more kind of granular. They said you had to be in the favorable characteristics. Remember then you would only get 2 cycles and low dose of radiation. And they were saying, well, could you just get away with 2 cycles of treatment? So how did we do? Well, the first is that UK study. And you can see here that the outcomes were outstanding in both groups. You could see if you didn't add radiation therapy, there was a little bit of a higher risk, about 5%, likelihood of progressing. This study was actually just updated in December, and if you look at long-term survival, in other words, did people have a bigger risk of dying, the answer was no. They actually had the same outcome in both arms and the same as the national average in the UK. But I think for patients, there were a little bit more of a group of patients that needed salvage therapy due to disease relapse. The European study, similar results, did show a slight decrement with the omission of radiation therapy. They called this a negative trial. And the German Hodgkin lymphoma study group showed the same thing, a slight decrease without adding the radiation therapy. So the consensus was just, you can leave out radiation therapy if you're PET scan negative. The challenge, however, is remembering you can salvage those patients, but clearly patients don't always like the fact that they've had to come around to more treatment subsequently. What exactly you call PET scan negative also matters. So from the German Hodgkin lymphoma study group, you would probably know that we use what are called the Deauville criteria. That's the amount of FDG uptake on PET scan compared to background. It's ranked 1 to 5. We typically will call 1, 2, or 3 negative, 4 and 5 positive. Here they just showed that if you just took 1 and 2, called it negative, versus 1, 2, and 3 called it negative, you can see that there was a difference. So exactly how your nuclear med team reads the PET scan actually makes a difference. But why does this matter to us in practice? So when this result of the RAPID trial particularly came out saying you could probably leave out radiation therapy, that was around 2016. So our practice said, we're embracing that and we're going to skip radiation if you're PET scan negative. But in 2022, with 5 years now of follow-up, we said, well, how did we do? And the answer was kind of rubbish. And what I mean by that is, you can see here are the patients who did in that prior era get chemo and radiation, and here are the people in the subsequent era who just got chemotherapy. And we said, well, wow, what happened? Because that's not exactly what was happening in the clinical trials. Well, it turns out when you go to practice and you liberalize things a little bit, and remember how I said a big mass is not a good prognostic factor, and extranodal disease not a good factor, when you don't follow what's exactly in the clinical trial, which by the way was very favorable patients, you get these kinds of results. So a cautionary note, just to say that while radiation therapy may have some toxicities, in my view it still remains important in how we manage patients, particularly if the disease is a little more advanced. So what about other strategies about how you might avoid toxicities, and could you use some of the new drugs that I mentioned to actually replace radiation therapy? Now, there's no randomized studies here, but these are some of the strategies that are being considered. Here, for example, is giving brentuximab vedotin, the CD30 antibody, in combination with chemotherapy. I'll show you more about this in just a second. And doing a PET scan, and if PET negative, you can just consolidate it with the second of those novel agents, and that's the PD-1 blocking antibody. And if PET positive, using both the antibody for blocking PD-1 and the antibody targeting CD30 and delivering toxicity, delivering a cytotoxic drug. And you can see that in this study, at the end of the day, 100% of patients after consolidation were in remission. So this is a strategy that obviously has merit looking to the future. The German Hodgkin lymphoma study group took those very favorable patients and added the PD-1 antibody nivolumab to it. Now, I will add they did add radiation as consolidation here as well, but the reason I show this is that it's really difficult to do better with a progression-free survival curve than you can see in this study. The outcomes here are outstanding. And finally, in the limited stage space, what about we just take everything we've got, put it all together, and hopefully get the best result that way? So what do I mean? This is chemotherapy, AVD, or just in this case, doxorubicin and dacarbazine, the two most active drugs. Add nivolumab, the anti-PD-1 antibody, add brentuximab vedotin, the antibody drug conjugate targeting CD30, and you put that all together. And as you can see, the response rates then are in the 95% range with a very good progression-free survival. This is not a randomized trial. This will need to be compared against standard therapy. So just to summarize limited stage patients, remember favorable and unfavorable, less chemo if favorable, more chemo if unfavorable. And I think PET-directed is valuable. However, it doesn't give you quite the same information as you think. PET negative actually says that if you drop the radiation therapy, your progression-free survival may decrease. Be aware of that. If you're PET positive, escalating therapy, which a number of those patients of those trials tested, may actually improve outcomes. So in my view, I've become a little more cautious about leaving out radiation therapy, particularly in patients who have more bulky disease and more poor prognostic factors. And the reason I think it's important is proton beam therapy and novel agents are changing the long-term side effect profile and may be beneficial. So, switching gears now to advanced stage patients. So in this case, we really had two strategies in the past. The first is you kind of start with lower dose treatment. And in that case, ABVD chemotherapy is this lower dose. And we do a PET scan after 2 cycles. And if you're not doing as well as you think, you crank it up. You give more chemotherapy. Possibly in the people that are doing well, you can dial it down. In the second group, you start high. You come in harsh and hard, if you like, and then if you've got a good response, you can limit how much treatment you can giving in a way to then prevent long-term toxicity. And again, PET-directed is the way to do this. So similar to what I told you before, 3 trials that are very informative. The first is the Rathel trial from the UK. Their whole approach was start low, and if you're not doing well, escalate, or start low and you are doing well, drop bleomycin, which is a lung toxicity, a drug that causes lung toxicity and therefore can cause problems. The German Hodgkin lymphoma group took the opposite approach. They said start high, come in with intense therapy, but you can cut down on the number of rounds of treatment based on a good response. And the French study kind of did the middle, if you like. It said start high, but rather than cut down on the number of cycles, drop down to the less intensive regimen, so go from escalated Biocop down to ABVD chemotherapy. So what did we learn from this? Well, firstly, from the Rathel trial from the UK, the main thing takeaway was that if you came and used ABVD chemotherapy, after 2 cycles you had a negative PET scan, you could drop bleomycin, which is the drug that can cause lung toxicity, and results can be exactly the same. That actually was very useful in practice, limited a lot of toxicities. What wasn't as clear, though, is could you escalate and kind of make up what you might be losing by intensifying treatment? The German Hodgkin lymphoma study group looked at decreasing the numbers of cycles of intensive therapy. So they used escalated Biocop, and they showed that you can decrease down to 4 cycles of treatment if it was PET negative. So they started out doing 8, they worked out you could go to 6, they worked out you could go to 4 and still maintain the results. One of the things that was interesting was that 8 cycles caused a number of long-term problems, including second cancers, and actually the outcome was worse by doing too much heavy chemotherapy. So again, lesson learned is too much can be as bad as too little. And the European study showed the same thing, that if you started with an escalated Biocop, you did 2 cycles of treatment and you were doing well, you could drop down to ABVD chemotherapy, minimize toxicities, and maintain the outcome. So that was kind of like the standard using PET scanning as a way to really refine treatment. But I mentioned to you now a number of times 2 additional new classes of drugs, and the question was how could you add that in advanced stage patients and get a better outcome? So the first one is brentuximab vedotin. So this shows you how it works. It's a CD30 antibody. It has MMAE, which is a auristatin derivative, so it basically interferes with spindle formation and tubulin formation. So it binds to the cell swallows the antibody that's stuck to CD30 and delivers the poison pill, if you like, right into the cell. And I showed you this picture earlier that all of the Reed-Sternberg cells are CD30 positive and very few other cells are CD30 positive. So the initial studies were done was to say, well, let's just take brentuximab vedotin and add it to ABVD chemotherapy. Turns out you can do that, but lung toxicity ends up getting to be substantially worse. So dropping out the bleomycin, remember I told you that was the one toxic drug from a lung toxicity perspective, and just replacing it with the brentuximab vedotin turned out to be a much better strategy. And as you can see, the outcomes in this initial study were really very good. So then it was, well, how much better is that? So brentuximab vedotin AVD chemotherapy directly compared against the standard ABVD chemotherapy, 6 rounds of treatment in each group, a PET scan done after 2 cycles, but didn't drive the decision making, just was for information only. And in this study, firstly, they showed that there was progression-free survival advantage by adding the brentuximab to the AVD chemotherapy. And then notably, there was actually an overall survival advantage for patients that received brentuximab AVD chemotherapy. And you might say, well, doesn't it matter? Isn't it important that you can just salvage everybody? This was actually one of the first times that said, no, actually what you do in frontline might actually matter the most, because even though you can salvage a lot of people, you may not salvage them quite as well, and the first time might actually be your best time. One of the things that is my sort of personal thought about this. Interestingly, people get second lymphomas who had Hodgkin when they potentially relapse as a second malignancy, and there were fewer of them in the group that got brentuximab vedotin. Could the brentuximab vedotin somehow have targeted a stem cell or precursor cell? Possibly, and that's maybe where the survival advantage came from. This was interesting because both in PET positive and PET negative patients, you can see that the addition of brentuximab vedotin brings the outcome up substantially. At the same time as adding brentuximab vedotin to a BVD chemotherapy was being explored, you heard me talk about the escalated intensive therapy called BIACOP that the Germans were using. They used brentuximab vedotin and modified their escalated BIACOP to call it BRICAD. And what did they do? Well, they basically decreased and took away the bleomycin, just like the ABVD group had. They used to give 2 weeks of steroids. They cut that down to 4 days of dexamethasone. They also took procarbazine, which ended up having a lot of toxicity on fertility and toxicity for second malignancies, and traded it out with dacarbazine, which was less so. The advantage of this regimen was just a few days, once every 3 weeks, and the treatment was going to be around 4 cycles of therapy. So they did the same thing. They took their escalated BIACOP and compared it to this new BRICAD combination. They gave 2 cycles, and in this case, they used a PET scan to determine things. So you remember I showed you how they had worked out that if you're PET negative, you can cut down the number of rounds of treatment. So if you were PET negative, you got 2 more cycles of BRICAD versus 2 more cycles of escalated BIACOP. If you were PET positive, you got 4 more cycles versus 4 more cycles. And the point was just, they just wanted to show it was less toxic, but just as good. Well, it's interesting, they actually showed, yeah, it was less toxic. Now, I will stress it's not non-toxic, it just has less toxicity. But what was really interesting is they actually showed it was better, and the outcomes were improved over escalated BIACOP, which already were pretty phenomenal. So again, as we're looking at the use of this brentuximab vedotin in combination with the standard chemotherapy, both regimens showed a substantial benefit when this was added in. The second drug that I mentioned already was the PD-1 blocking antibody. So I mentioned to you copy number gain, amplification of the locus, lots of expression of the cell of PD-L1 on the tumor cells. So simply using nivolumab in relapsed patients had already shown to be significantly beneficial. So the question was, again, could you now simply take nivolumab, PD-1 blocking antibody, and add it to AVD chemotherapy? And here you can see the phase 1 study, again showed yes, you could do it, and the results looked really promising. So a very similar study was now done, comparing nivolumab AVD chemotherapy to what I just showed you had become a standard, brentuximab AVD chemotherapy. 6 cycles, head-to-head. Need to call out Dr. Cole. He and the cooperative groups kind of led doing this particular trial. 2 things that I think were interesting. They specifically went and included young patients, in other words, less than 18, which many times have been left out, so 12 to 18-year-olds, and over 60-year-olds, which, again, many trials had left out because of the intensity of therapy. Some of those patients did need to get growth factor. If you get brentuximab vedotin, you definitely need growth factor. It was optional in the patients getting nivolumab AVD. Again, this data was just published last year, but you can see a significant benefit for the addition of nivolumab AVD chemotherapy over the brentuximab, which had already been better than a BVD chemotherapy, so pushing the bar higher and higher. I think what was very valuable in my mind from this is that if you looked at old patients, and again, 60 and plus were regarded as old, but the reason this is important is treating people with older age with these particular combinations are often very hard to do. Patients don't tolerate them well. Because they don't tolerate the regimen well, they don't actually have a good outcome. Here you can see the outcome for those receiving nivolumab AVD was actually excellent, mainly because I think it was well tolerated. And similarly in the pediatric patients, the use of nivolumab AVD chemotherapy was better than brentuximab vedotin AVD chemotherapy. So all told, in all groups, this was a superior therapy. So coming back to what I told you with limited stage, well, what about we just take all the best stuff we got, put it all together in one go, and see how that does? So in other words, it's taking our two best chemo drugs, doxorubicin and dacarbazine, adding brentuximab vedotin, the CD30 antibody, and adding a PD-1 blocking antibody, put the whole lot together. So again, not a randomized study, but promising results here showing response rates that are 95% doing that and putting it all together. So if you were to say, what have I learned from what I just told you all about? If you have a limited stage patient with favorable characteristics, standard have been to give 2 cycles of chemotherapy, a BVD chemotherapy, and 20 gray, low dose of radiation therapy, and a very high percentage of patients are cured. Data would say if you leave out the radiation in this particular group, they don't do that well, so I would say that remains a standard. I think you could leave out radiation therapy in low bulk disease patients with more unfavorable characteristics, in patients where you're going to radiate the breast in a female patient, patients where you're really concerned about the location close to the heart. But I think for patients with more extensive disease and larger masses, you should really consider maintaining the radiation therapy because the results are good. And in advanced stage patients, nivolumab AVD chemotherapy in the US has really become the standard. I think particularly because it's valuable in the elderly, in the pediatric patients, particularly in all of the lower risk groups. Could there a case be made for the BRCAD regimen in the high-risk patients based on how good escalated BRCOP was in that group? I think that's something that's open to debate. So with the last few minutes that I have, I wanted to say, well, what about you did the right thing and managed the patient exactly according to the book, but darn, the patient is back with a recurrence and what to do next? Well, again, I would say that the standard has been to ask, is the patient eligible for an autologous stem cell transplant? Because the principle has been, if you didn't get it the first time, go in harder the second time around. Salvage chemotherapy, beat the cancer down, and then go to an autologous stem cell transplant using the patient's own stem cells. I'm going to share with you a few of the nuances around that. So the first thing is that salvage chemotherapy. What have we learned in recent times about how to do that better? So the first thing that is important, and I will stress that this is a little bit of a moving field because as you saw from what I just showed you, what you do in frontline has changed. Back in the day, you used to give chemotherapy only. Then there was using brentuximab chemotherapy. Now it's nivolumab chemotherapy. So the question of what you do subsequently, I think, largely comes down to what you did initially. If you used one of those agents before, the next question is, did the patient progress on the therapy, or did the patient have a great result, there was a window of time, and now it's back, so whether you should use the same drug again. But a few things that we're learning as we go along. Adding a PD-1 antibody to chemotherapy is really a very successful strategy. So GVD is one of the regimens that is often used as salvage. Adding pembrolizumab in this study from Memorial Sloan Kettering showed a significantly high response rate of 100% with 95% CR rates. Those are numbers that we don't typically see even in this very chemosensitive regimen and disease. The second is a similar principle, a different chemotherapy. This is ICE chemotherapy, but again, adding a PD-1 antibody to it. I'd never think you should call a regimen nice, but again, I guess that was what the decision was. But again, very high response rates, high CR rate, majority of patients able to go to a transplant. So taking that information, a multi-center study asked the question, if you added a PD-1 antibody to salvage chemotherapy, if you add brentuximab vedotin to salvage chemotherapy, or you just simply did old school salvage chemotherapy, what was best? And you can see here that adding a PD-1 antibody seemed to have made a substantial difference to the overall outcome for the patients who subsequently go to transplant. So my takeaway is if you haven't used a PD-1 antibody, this is the time to bring it out. The second thing that is interesting data that was a little older, kind of dropped a little out of favor, now has become more relevant, is the use of brentuximab vedotin as consolidation after transplant. So remember, we were, for many patients, giving brentuximab vedotin as initial therapy, and that complicated whether you should use it again after a transplant. Now that we're more typically using a PD-1 antibody in frontline, I think this brings this back into the picture. So this study really said if you had a transplant, things were going fine, there was then a comparison of using brentuximab vedotin as consolidation for up to a year after the transplant compared to just stopping, which was the standard of care, particularly in the high-risk patients, and these were the 3 high-risk groups. You can see that the outcome in each case was better by adding brentuximab vedotin. So I think if you haven't used that before, principle here is consider using it now. In contrast, if you actually had failed, in other words, progressed after an autologous transplant, this was a comparison of using the PD-1 antibody directly against using the brentuximab vedotin anti-CD30 antibody in the patients who had relapse post-transplant. And you could see that PD-1 blockade was the winner in this kind of direct comparison. So finally, what I wanted to talk about is, so you heard talking about frontline treatment, you heard about salvage followed by an autologous transplant, and in some cases, consolidation after transplant. What about you did everything right, and heaven forbid, the patient has relapse disease after failing an autologous transplant? What options are available to you? So just to say, there are a few. The first is CAR T cells are being developed in this space. So most of you are familiar with CD19-directed CAR Ts. Those are for B-cell lymphomas. Those would not be particularly useful here because the tumor cell does not express CD19, but it expresses CD30. I showed you some of those pictures. So CAR Ts have been developed that target CD30. Now you can see from this slide that they are not quite the same success story as they might have been in B-cell lymphomas. And part of it is, while they have a high response rate, the durability of the response has been a little bit disappointing. So while they're promising, there's a lot of tweaking that still needs to be done here before we can really say this is going to be the way of the future. The second strategy you could consider is, remember I told you immune checkpoints were really important. The interaction between the tumor cell and the microenvironment is a very relevant thing in Hodgkin lymphoma. So if one checkpoint was valuable, well, what about 2? So here you're going after a second checkpoint. So this is LAG3, and this is favelisumab, which is a blocking antibody for LAG3. So in this study, patients had already received a PD-1 antibody and failed it. Now got continuing that PD-1 antibody, but adding a second one. And you can see that while not everybody had an official response, most people had some degree of benefit, and this may be a strategy moving forward. And then finally, what about utilizing other cells? So you remember I showed you that the monocytes, the macrophages, the NK cells were all present within the tumor. These express various receptors that could be engaged, and this is a strategy of using a bispecific antibody. On the one hand, it binds CD30, grabs onto Reed-Sternberg cells. On the other side, it has CD16, which allows it to grab NK cells or monocytes and macrophages. In this study, they actually took NK cells from cord blood, they activated them, and then they pre-coated them. In other words, kind of like a poor man's NK CAR T, and infused them into patients. And you can see the response rates were very high, looking very promising. The challenge remains here the same as CAR Ts, in that it's not very durable yet. But again, I think there's opportunity for improvement. So what do I hope that you would hear, and as I would just share here, outside of a clinical trial in relapsed Hodgkin lymphoma, what are my choices? I think if you haven't used a PD-1 antibody, we typically will use that in combination with chemotherapy. If you haven't had brentuximab vedotin, we typically will use it as consolidation after transplant. If you got these drugs before, and particularly if you progressed on them, I'm not sure that that's your best strategy. So here's just a little summary slide that takes us back to the beginning where we spoke about all these interactions. I'm just showing you multiple drugs that are all trying to disrupt those interactions, targeting different proteins that are on the outside of the tumor cell, and I hope I've convinced you that many of these strategies have been highly beneficial and successful. So takeaways that I would hope for you in your practice, particularly if you do oncology practice, new agents, CD30 targeted antibody drug conjugate, PD-1 antibody, really need to be utilized in frontline therapy. Adding a PD-1 antibody in Salvage is really important. But remember, until every single patient is cured, we are not done yet. So if you have a patient who would fit a clinical trial, we're always pushing the envelope and testing the boundaries, and I'd encourage you to participate in that. So with that, I'll end, and thank you for your time and attention, and I'm very happy to take questions.
So I'm sure the oncologists do. Dr. Bartlett?
I was saying Nancy was going to ask me a tough question. All right, I'm ready, Nancy.
I'll start with the one, when you were presenting your data, the retrospective data, after you guys stopped using radiation and you showed the difference in PFS, has there been a difference in your survival for your Hodgkin's patients over time, meaning worse?
So we haven't published that, but we did look at that, and the answer is no. So to the point, and I think it bears out what was shown in the RAPID trial, a lot of those patients can be salvaged with subsequent strategies. But as I alluded to, patients, they say that's fine and well for your publication, but in my life, I don't want to relapse, thank you very much. I'd like you to get it right the first time. So again, we're a little more cautious now about making sure that even though we know we can kind of pull things back, we're just not, and also because we standardly will use proton beam therapy, I think the toxicity profile is different. In more bulky patients, patients with a little bit of extension outside of the lymph nodes, those were actually not in that RAPID trial, and we started to sneak those into our strategy, and so we stopped doing that.
So are you willing to accept any PFS difference?
That's a good question. I would actually say personally, if I'm a patient, no. And the reason is just if I look back at breast cancer trials and other things, we see 2-3% differences in very large studies, and that is really regarded as critical. Now, I will concede that we don't salvage those people as well subsequently. But many patients, particularly, and I know you in your practice is similar to mine, if I'm 25 and I'm 22 and I'm in the middle of my college career and I have this, I want to be able to go through the 6 months of hell that this will take me through, but then I want to be done. And fair enough, I'm not sure I want to come back when I'm 55 or 65 with a second malignancy, but I think most patients would prefer not to relapse. And so I've tended to be a little more aggressive in the radiation side of things.
I think that's interesting. I guess we've probably been at this about the same amount of time, maybe a little bit longer, but I don't know, I get so upset when I see the patients who are having a cabbage at age 35, and I have one of those patients, and you have patients who have secondary breast cancers, which are usually favorable because you're screening for them, but not always. And so I do think there is a trade-off.
And I think you're right, and I do think that's where your clinical judgment can really come into play. So if you have a mass that's sitting right on the heart, if you have a woman where you're going to unfortunately need to radiate the breast, or the disease will be in the breast will be in the radiation field, I think that's a case to be made. But I do think it's one of those which I have a really open and honest conversation with the patient, making sure that they are part of the joint decision making.
Up at the top there.
Oh, I was just going to offer as probably the token radiation oncologist in the room. Although Dr. Ansell, you're doing an amazing job explaining the risks and the benefits. I do think modern radiation is very different from radiation of the past, but I do agree with you that for every patient, the disease is unique, and the distribution of the disease is unique, and the characteristics of the disease are unique, characteristics of the patient are unique. So definitely they warrant a really thoughtful conversation about potential long-term side effects.
And again, I just want to reiterate, and you should set me straight if I'm not honest about this, is that imaging modalities to actually do the simulation for radiation therapy are dramatically different to how they might have been 25 years ago. And the actual administration, and particularly the form, the molecules that are being used to give the radiation are different. So I think we'll only learn about the current long-term toxicities in probably 15 or 20 years from now. But I would say I would be very disappointed if they weren't dramatically less. Hunter.
Hi, great talk. When you brought up the data about the PD-L1 testing of the tumor and how patients do differently
Yeah, very good question. I would say that, again, just remind you that that data was in the relapse setting, but I will say it's the expression of PD-L1 and PD-L2 on Reed-Sternberg cells in Hodgkin is bright and brighter. So it's not sort of like, well, like in other tumors where you can have negative, none are negative. Also, I would point out to you that the progression-free survival curve was good and gooder, so it was like great and excellent. So we tend not to bother with that. We just tend to go ahead, but I think it illustrates the fact that there is some biology in there. Now, I'm going to put out something now that is heresy for many, but I think is actually interesting, at least for me, and that is that exactly how PD-1 blockade works in Hodgkin lymphoma, I think is profoundly different to how it works in all the other solid tumors in which we give it. And the reason is there is genetic amplification of the ligand, on the PD-L1 and PD-L2 on the tumor cell. And interestingly, there is reverse signaling that happens through PD-L1. And so I think in Hodgkin lymphoma, and this is where the heresy comes, PD-L1, PD-L2, and PD-1 interruption has nothing to do with T cells. It has to do with the reverse signaling. And where I get that from is, if you've ever seen a patient with a really big mass in which you give PD-1 blockade, those patients don't get a reaction, in other words, like everything got bigger and worse. They immediately just get better. It's like you switch something off, not switch something on. So my hypothesis is, and we showed this in a paper that we presented a few years ago, that by interrupting PD-1 interactions with PD-L1, it's that signal that's going back into the Reed-Sternberg cell telling it to grow is just being switched off. So it's like the cops came at the party and turned the lights off and everybody went home. The whole thing stopped.
I'd like to follow up on that with the...
Hang on just a second. No, go ahead.
My question was a bit about the survivorship and the long-term toxicity. Has there been a relationship between the milieu of Hodgkin's, whether it's virally driven or inflammatory driven, and the association with long-term toxicities like secondary cancers or cardiovascular disease?
Yeah, that's a great question, and to the best of my knowledge, no. I think there's been some data around EBV positivity and not really showing that distinguished patients. This most recent kind of classification was only described a year ago, so I don't think anyone's looked at it long term. But I think that's a good question, because your hypothesis might be the genetically driven, shall we say, proliferative tumors may do differently to the immunologically affected tumors. So great question. I don't know that we have data for that.
You bring up the concept of the microenvironment for these tumors. I would consider angiogenesis, the tumor invasion, as a different process from proliferation of a current tumor cell, which is a bigger one. Can you speak to the differentiation of that? We tend to lump those in terms of progressive-free survival, overall survival. It's a way to distinguish whether you're actually delaying growth of the tumor as opposed to shrinking the tumor for some period of time and then it starts to grow.
Yeah, so you're asking a great question, and I don't know that we have good data to answer it. So what we don't know is, are there different microenvironments within Hodgkin lymphoma? One that is more, let's say, cellular-driven, one is more kind of angiogenesis-driven, and the like. One of the challenges, and the reason we don't have that data, is that it hasn't seemed to matter, because when you treat patients, what you see all the time, we talk about within 2 cycles of therapy, we're looking for what we call a complete metabolic response, which means like there's no active cancer going on. So whether you had differences or not, different to solid tumors and other kinds of cancers, you're getting such a dramatic response so quickly, it really just seems like it was more about multiple cell types than about structural things, because you do get a shrink of the tumor. Sometimes you do get residual masses that remain, but most of those are sort of stromal components, not as much angiogenesis and the like. But nobody, to the best of my knowledge, has gone in and kind of sampled those tumors to really get a good understanding of the tumor microenvironment in a complete responding patient. So I think it's a very good question that I don't have a good answer to.
Thank you. This is a wonderful talk and great summary of the data.
Yeah, so you're asking a good question. Two parts to the question that I'm hearing. So the first is, should you manage HIV patients differently to others? And I would argue, provided you've got HIV under good control, the data so far would say no. In other words, outcomes are very similar if HIV is well controlled using the same therapy. So our strategy has always been, get the patient on appropriate HIV therapy. As soon as they are and things are stable, you go ahead and treat them just like the next person. But the second question you're asking is a little more tricky, and it's actually a good one. BV-AVD or BV-based, that's brentuximab vedotin-based therapies have been shown to be equally effective in HIV-positive patients. We do not yet, and I stress the word yet, have that data for patients with getting nivolumab or a PD-1 antibody. I wouldn't predict that there wouldn't be difference, but remember now you're doing an immune change, and I showed you viral subtype. And so is there going to be a difference in the viral subtype or going to be a difference across the board? I don't know. But I think in principle, don't jeopardize the therapy of an HIV patient by giving less therapy in any way. So whatever the standard is in this institution or others, I would use that in a patient with HIV and deal with the consequences rather than assume stuff that we don't know.
Great talk. I was curious, Asheville today, and this group at Stanford put forward a classification based on ctDNA primarily up front, newly diagnosed patients, and they seem to have some differences in clinical outcomes. You didn't talk about that in your talk today. I was just curious what your thoughts were on that.
Yeah, so the main reason I didn't talk about it is I'm trying to make sure this is a topic that's not just about for you and me, so I did show you the German Hodgkin lymphoma study group, similar data. So that is ctDNA driven out of the peripheral blood. So yes, I do think there's some differences in there, but I think we're starting to see sort of similar stories coming out. So one that's really kind of very immune mediated, one that's much more kind of genomically driven or actually some kind of mutationally driven. And then I think whether or not there's a viral component, yes or no, I think is a little bit still in debate. But I think those are, in my mind, kind of a little bit more about where we're learning things, is to say, is it really just a single genetic thing which then causes tumors, this Reed-Sternberg cell, to recruit all these cells, versus is there more going on in the tumor itself where there are multiple genomic errors, and it's a little more autonomous, if you like, from what's going on in the microenvironment.
That was really terrific. Thank you
Thank
so
you.
much.